Greetings. I'm Carol Molinari, an associate professor in the Health Systems Management program at the University of Baltimore in Maryland. I have lived in several regions of the United States and have experienced several different models of healthcare. I will base my comments about the U.S. healthcare system and its 2010 reform from my work as a healthcare management academic, a trustee, and perhaps most importantly, as a consumer. I plan to briefly discuss two key components of the Affordable Care Act, namely the health insurance exchanges designed to provide affordable and comprehensive health care coverage, as well as the long-term delivery reforms to help reduce unnecessary and costly care while coordinating the quality of care for its users. These are particularly relevant as Iran launches its own current reform to rein in its high healthcare costs. Given the strong private sectors in both countries, the lessons learned will involve how best to bring about change in the delivery of care and how to safeguard the collective health of the country by monitoring its costs and its quality. Healthcare costs are clearly the driver for reforms, both in the United States as well as in other countries. When we look at this graph, which spans 30 years, we see that in the U.S., healthcare costs have been excessively high, especially when compared to the other developed countries. We in the United States pay the most for our healthcare. Yet, we only have average life expectancy and other health indicators, like levels of disease, etc. Granted that healthcare has the least impact on the health status compared to factors such as environment, lifestyle, and heredity. Yet, these excessively high levels of healthcare spending begs the question, what is the value and benefit of spending so much on our healthcare system? Having the most expensive healthcare system in the world has had its consequences. By the mid-2000s, a growing number of Americans were without health insurance. This was caused by a number of factors. As healthcare costs were increasing, so were healthcare premiums, making it increasingly unaffordable to a growing number of Americans. Employers who provide 60% of Americans with employer-based health insurance were also dropping health insurance as a benefit due to rising healthcare premiums to them. Workers were losing their jobs due to the recession and thus lost their health insurance. And finally, health insurers themselves were dropping or denying coverage to those with pre-existing medical conditions who were high users and thus were incurring high costs. By 2008, healthcare reform became a key presidential campaign issue. When President Barack Obama was elected, he made healthcare reform a cornerstone for his first term in office. Through efforts of the Congress as well as the President, the country passed the Affordable Care Act, 2010 Affordable Care Act, also known as Obamacare. The two main pillars of this complicated legislation involved first addressing the issue of access to care by providing a comprehensive yet affordable health care plan for Americans. And the second area of reform involved making changes in how care was paid for and delivered in this country to ensure the long-term financial sustainability of our American healthcare system. Continuing with the reforms in terms of the delivery system under the Affordable Care Act involves really provider payment change. American providers have historically been paid on a fee-for-service basis, which means they get paid for every service rendered, creating really an incentive, if you will, to do more as a way of bolstering their revenues and income. with many years of research behind this form of payment, we see that it has fee-for-service has been a factor that has driven up the amount of care that we provide in the United States, as well as the costs of care that we have seen and the inflation in costs. With this new legislation, with the Affordable Care Act, there are now incentives in place to encourage providers to accept a different form of payment, a bundled or capitated amount, rather than fee-for-service, in the hopes that this kind of a payment structure would reverse some of these incentives. Rather than doing more services, would in fact provide the incentive to better manage the health of each patient, and thus in turn keep the cost of care down to more manageable levels than what we have seen in the past. A second area for reforming the system involves creating systems of care. In the United States, providers have pretty much practiced independently, so that when a patient requires a variety or a continuum of care, especially those suffering from chronic diseases, they often have to go to multiple providers in multiple locations and settings. The concept with a system of care is that this would provide to the consumer a way of accessing a variety and a continuum of services typically in one location, and so it would provide more convenience, but also help better coordinate the care to manage the individual patient's needs, especially those that are involving helping them manage a chronic illness. What we know is that again, this kind of lack of coordination that we've had in the past when we've had all these various independent providers, it has really caused a significant fragmentation of care. So this legislation is trying to address that lack of coordination and fragmentation by creating incentives to create and establish systems of care for the patient. Now we're going to look at Iran. Iran has gone through some significant improvements in terms of its level of health in the country. As indicated in this table, we see that there's been a marked improvement in life expectancy, as well as a marked drop in infant and maternal mortality. All very much indicative of a society that was, and that is improving in terms of its overall health status. We also know that Iran's socio-demographics have been changing and improving. We have seen more Iranians gain in education, and their literacy rates have increased significantly. We also see that that their income levels have gone up. And we see increased levels of urbanization across the country, meaning that more people are able to, more people are living in cities, being able to access jobs, income levels go up, and with that we see increases in their living and health conditions. According to a recent report in the Financial Times in March 2014, Iran has been experiencing some extremely high rates of inflation in terms of its health care costs. We know that from 2005 to 2012, national health care costs in Iran have gone up 400%, fourfold. This is particularly a concern to the nation and its citizens because in Iran, most individuals and families pay up to 70% of their bills out of pocket. So as costs go up, so do the costs for the average Iranian individual and family. In the case of a serious illness, a low to middle income family could easily become financially bankrupted. So we see that that high inflation in terms of healthcare costs is a very significant factor and problem in Iran. What I'd like to discuss next are some possible contributing factors and forces that may be fueling some of these high rates of growth in terms of costs. To better understand why Iran is experiencing such high rates of healthcare inflation, let's look at some of the changes happening in the delivery system. Over the past few decades, the public Iranian system has become replaced by private providers, in which providers are no longer paid by the government, but instead depend on generating their own revenues and profits for their services. We know that the supply of physicians in particular over this period of time has increased. More physicians are practicing in private facilities, especially those in growing urban areas. Also, we know that fee-for-service is the dominant provider payment structure in place in Iran. So what we're starting to, I think what we probably have seen are that as more physicians and providers crowd health markets in Iran, they order more services to sustain income levels and remain in practice. These economic forces obviously create some supply-side demand. We have seen this happen in many other countries, of course, the United States being probably first and foremost. So it's important to look at this and to see to what extent this is happening. This may be happening in Iran. Another area another source of demand to be looking at involves demand that comes from the consumer. And I'd like to just note that in Iran, we see that they have an extremely high C-section rate. As this graph indicates, over the period of from 2000 to 2005, we see very, very high rates of C-sections, 35 to 40%. And we know that these rates have been sustained in terms of current times. What these rates suggest is that women are seeking medical solutions for non-medical conditions. It may be for convenience, it may be for other cultural reasons in terms of thinking surgical delivery is a safer or is a preferred delivery. Perhaps, not wanting to go through the time and exhaustion and effort to have a regular delivery. Maybe, again, some possible reasons why we are seeing such very high, excessively high rates of C-section rates in Iran. We know that these rival those of other countries like Brazil, which has the highest rate, then China, as well as the United States. Iran is making very significant strides in terms of healthcare reform. President Rouhani has decided to provide government support of a private medical insurance for Iranians who cannot afford care. That means between 5 to 12 million people under this plan will now be able to obtain their health care at a reasonable rate of out-of-pocket expense that'll go from 70% to about 30%. This is expected to go into operation at the beginning of 2015, so next year. So a huge first step in terms of increasing access to care among the citizenry of Iran. Another consideration, hopefully, that will be looked at some point in the future is ways in which the delivery system can be reformed so to ensure that healthcare costs in the future can be controlled and be maintained at more sustainable rates. As I mentioned earlier, there's been changes in the delivery and the payment of healthcare in the United States, moving from fee-for-service to a fixed capitation rate for providers, and that may be an option that Iran would like to consider as a way of keeping and reining in its healthcare costs in the future. So with that, I'd like to conclude my video and to say thank you very much for your attention, and I wish the best to Iran in its future reform endeavors. Thank you.